Well, ladies and gentlemen, we're going to go from the technical to the absurd. I just have to figure out how to advance all of this, and I think we can go. Bill Roth was a Swiss surgeon, and some of you who are older may recognize he was a gastric surgeon, the Bill Roth 1, the Bill Roth 2. He was quite famous. And he said, only the man who is familiar with the art and science of the past is competent to aid in its progress in the future. And what I'm going to do is spend the next few minutes talking about spinal deformity and its history. It was well known many thousands of years before the birth of Christ, and we're going to talk about from ancient Egypt up to modern day. Now, the records, at least 4,000 years, almost 4,000 years before the birth of Christ, from India, did talk about axial traction, presumably for correction of kyphosis. There's no clear records. Whoops, I did something wrong here. There. Now, Smith, the famous archaeologist, discovered papers describing traction for the treatment of deformity in the papyrus papers, and here's a copy of one of the papers. If you can read that, you're better than me, but it has been translated, I can guarantee you that. 17 to 16 BC, the boxing boys with spondylolisthesis were illustrated, and you can see here on the extreme right hand an example of a spondylolisthesis. This is taken, of course, from a fresco. And so deformity was recognized way back. Aristotle was in the 4th century before Christ, and he founded the basis of comparative anatomy, and I'm sure Dr. Tubbs will talk to us a lot about that. Now, Hippocrates introduced bracing, and you can see the corrective technique for correcting a kyphosis, probably most of them secondary to TB. They took bandages, cloth bandages, soaked them in blood, animal blood, and made them stiff to try to maintain correction of the deformity. And here we are some 2,000 years later when I was doing my residency in early practice, and almost the same thing as Hippocrates type of table 2,000 years later in Toronto. He introduced the words kyphosis, scoliosis, let out the evil spirits from the brain through burr holes, described the blood supply to the spine, the external blood supply, and described normal curvatures of the spine, kyphosis, lordosis. At his time, until the Middle Ages, essentially surgery consisted of bloodletting to let out the evil spirits, setting fractures, and making burr holes. Galen, who was also a famous anatomist and ostracized by the early church, did help also coin the words kyphosis and lordosis. He described the anatomy of the exiting nerve roots, and he experimented in animals on cord transection in various forms to see what would happen. He was imprisoned for some of his work. The Middle East, as you know, was very prominent in science in the Middle Ages, and spinal trauma was discussed, axial traction in both what is today Iraq, Iran, and in Turkey. If you go to London, one of the things you should visit, which not many people do, is the Queen's Gallery in Buckingham Palace. In there you will find this drawing done in 1833 of a scoliotic patient. So it was well recognized way back. Now, for many centuries, the only form of treatment for deformity was bracing. And here are some of the early braces from the 17th, 15th century, and, you know, fairly crude, not the modern form of applying distraction and derotation that Dr. Dubassé showed earlier today and many others have done. Modern bracing really began with this man in Milwaukee who was Blount. Dr. Blount, and initial brace, as you can see, produced a deformity under the jaw of the patient, and that was discontinued to the more modern form, which is still used, and many modifications of that in the ensuing years. Now, the first recognized surgery on a patient was done in the 10th century, when after a battle, when a slave was struck across the back with a stick, a stave, was rendered paraplegic. A laminectomy was performed. Unfortunately, history does not record the outcome. But if you consider that within 1 year of injury in the First World War, where soldiers were rendered paraplegic for one reason or another, 90% were died within 1 year. Well, I can imagine this patient in the 10th century probably expired fairly soon as well. This man from France was the modern father of children's orthopedics and spinal deformity. Vesalius, the great anatomist, also contributed a lot to the understanding of spinal biomechanics. Now, early surgery was carried out first in France, then Germany, and subsequently the United States. Guérin, in 1839, described posterior spinal surgery. Anterior surgery was not presented until the beginning of the 20th century, and by Kostuik, and then subsequently in the US by DeForest Smith. Guérin did myotomies of spinal musculature and then braced the patients. Now, at that time, deformity was either due mainly to poliomyelitis or to tuberculosis. And obviously doing myotomies was probably rational thinking at the time, but many people criticized him, including Velpeau, another Frenchman, when he reviewed Guérin's cases. And you can see the results from Guérin. 13 slightly improved, 7 got lost correction, 6 got worse. He was so maligned that he was banned from practice in France and was sent to Belgium to work. Malgaigne, who is better known by the pelvic surgeons for his classification, said, "It is important to know what to do, but no less important to know what not to do." So true today as well. Now, early surgery, as I said, consisted of bracing, traction, early surgery, and as I said, deformities were mainly felt to be due to poliomyelitis, which has been the great orthopedic teacher, certainly up until the 1970s. Now, fixation of the spine, early fixation, was attributed to 2 people in the United States, actually, where the Hydra from Texas wired the vertebra as a means of immobilization in fracture and in tuberculosis, Pott's disease. He used silver wire, but as you can imagine, the malleability of that wire probably broke fairly quickly, and there was no fusion done. This man was the first to introduce pedicle fixation. It's unfortunate the FDA did not learn of this, and I would have avoided many hours in court defending the use of pedicle screws in the 80s and early 90s. Anyway, he wrapped silk soaked in carbolic acid around the pedicles. He was an army surgeon in Kentucky. Volkmann from Germany performed the first rib resections and is better known probably for Volkmann's ischemia of the lower extremities from trauma and other things. Major advances occurred subsequently with improved casting techniques, so on and so forth. Bradford, not related to Dave Bradford, another Bradford, was the first chief of a first scoliosis clinic at Children's Hospital in Boston, and you can see here applying corrective maneuvers to a child with deformity on the Bradford frame. Lange, another American surgeon, used a steel rod attached to the vertebra by wires, and you can see where it protruded in the lower end. He presented his paper at the American Orthopedic Association meeting in 1910, the oldest orthopedic association in the world, and he was severely criticized. Further evolution and fusion took place. This is a technique of Albee, who split the spinous processes and took a tibial graft and put it in between. I did this in the 60s and early 70s. It was still relatively popular at that time. This is a picture of Albee from New York. Now, simultaneously in New York, the other end of Manhattan, Russell Hibbs, that should be Hibbs, not Hobbs, I apologize, first recorded 14 operations on scoliosis, stressing a fusion technique. And his fusion technique shows decortication of the posterior elements. Now, he did not do a facet fusion, but he decorticated. And you'll notice the use of a gouge. I do not recommend that surgeons ever use a drill to decorticate. This produces twice the surface area as fusion as when you use a drill to score the cortex of the posterior lamina. Anyway, Hibbs was also ostracized. He was forced to quit practice where he was, move out, and his peers did not like him. You'll hear more about him later on if you go to the 50th anniversary of the SRS in Minneapolis this autumn. Kleinberg, also another American, talked about fixation. He believed that fixation would help producing at least a fibrous union, but rather than a bony union. A report in 1941 to the American Orthopedic Association of 425 cases. They looked at fair to poor and 70%, good to excellent, and so on. You know, it's very fascinating that this paper in 1941 produces the same results that we talk about today. In orthopedics, at least, and I'm sure in neurosurgery and spine surgery, that 70% is still the figure that's good, and the rest are fair to poor. Hasn't changed. The outcome measures have changed, however, for the better, I think. Risser from Los Angeles talked about correction using a turnbuckle cast. This was a major advance, and I did a lot of this in my early days. Here's a picture of him. He also described other things in deformity surgery, and here was his cast that he put on, and then you cut a window in the cast behind and performed a posterior fusion. The problem was this was very high infection rate because these kids were often in casts for up to a year. And you can, even though the casts would be changed, you can imagine the bacterial content on the skin, as Dr. Anderson talked about earlier. In Toronto, the measure also did this with kids. They would hang them this way for 3 months. Now, you parents in the audience, can you imagine your child like this? But at that time, you know, was accepted. And then put into a cast and then operated through a window. Cobb, who is really one of the great modern people, after the war, instructed a number of people from around the world on surgical techniques for deformity, and he described the measurement of the deformity. But he also said something else. From our experience, we've been quite pleased with the results of cancellous bone bank bone for supplemental bone and scoliosis fusion. But it does not take the place of a good technique in doing fusion. And today, I'm afraid that a vast, significant number of spinal surgeons don't know how to fuse the spine. They know how to put in pedicle screws, but they don't know how to do a fusion. James, who was the chair in Edinburgh, initially at the Royal National Hospital in London, classified curves. 109 degrees is up to 100 degrees was severe, 70 to 90, and mild. Now, he's a fascinating man. He did a lot. Because the non-union rates were so high, he would explore all these children at 6 months postoperatively. He had a more fascinating history. During the Second War, he was parachuted into Yugoslavia as a commando, where he assassinated a number of German troops as a commando with the British Yugoslavian forces. At that time, kids spent a year in hospital. Pseudoarthrosis rate, infection rates were very high, as you can see, and maintenance of correction was very low. Instrumentation developed a little bit further. This is a spring developed by Gruka in Poland, initially developed for the treatment of fractures. I thought this would provide dynamic correction. The problem was that the hooks just eroded through the lamina, as you might expect with a spring in this fashion. He was an interesting man. Came over while the Cold War was still on. Very intelligent person, but died prematurely. I spent some time in Russia looking at allograft transplantation in 1969. I went over there. They were advanced at that time in the world. And I met this man, Kazman, who instrumented every deformity from the pelvis using 2 jacks. The failure rate was almost 100%. So that was abandoned after a few years. And here are some other forms of technique, including early pedicle screws and hooks placed to correct deformity. In the 1960s, saw major advances with the use of discography by Carl Hirsch from Sweden, electromyography, oil-based myelograms, posterolateral fusion introduced by Wiltsey from Los Angeles, McNabb from Toronto, the occasional anterior lumbar fusion and anterior cervical fusion by our friends from Hawaii, Michigan, and Johns Hopkins. Harrington rods were introduced, not compression rods. Spinal stenosis had been described in the early 1800s in France by Portel, but was really popularized by a famous neurosurgeon from Holland, Verbiest. Verbiest was not liked by his colleagues. They thought he shouldn't be dealing with bone, and he was ostracized by the neurosurgical community, but I must say welcomed in the orthopedic community at that time. This is a picture of the most famous deformity surgeon of all time, Paul Harrington. Dr. Harrington's instrumentation is shown here. Very simple, didn't cost much, and it provided compression, distraction through each end. Now, distraction will correct a mild curve, about 50%, but it also flattens the back. And it only corrected at the mobile ends and flattened the lumbar lordosis. So it was a big problem. There was a significant evolution since the development of Harrington instrumentation over the years and up to the current time. There is a Harrington distraction rod with the compression rod on the convexity. Unfortunately, the compression rod just increased the thoracic lordosis, didn't do much, and most people abandoned using it. Here's an example of an adult, which I did in an older adult, age 52, in 1969. Harrington was the greatest stimulus to the development of spinal surgery, and this led to the formation of the SRS, which is holding its 50th meeting this coming October in Minneapolis. And the first meeting was a collection of individuals, actually started by a resident out of New York called David Levine. This is a picture of John Moe shown with the very famous French surgeon Cottrell and from Paris, and Leatherman from Kentucky. John Moe is really the father of modern fusion. He was a tremendous man. He introduced facet excision. He was a great teacher. He, together with John Hall from Toronto, convinced Harrington to add fusion to the rod technique, because Harrington's initial procedures were only implantation of the implantation and no fusion. Needless to say, without a fusion, those rods would break. Also, when Harrington presented his early results to the American Orthopedic Association, he was literally booed by the audience. So things changed, obviously. And this man, Moe, did many things, but moreover, he was a great educator. He was the first president of the SRS and did a number of different things with reference to deformity. Another great person was Stagnera from France, who introduced a distraction technique and the modern form of neurological monitoring, the wake-up test, which is still the gold standard to this day, some 40 years later, 50 years later maybe. He is also very interesting in that his hobby was winemaking. And I had the opportunity with Dr. Dubussé and Madame Dubussé of drinking some wine in Lyon with him many years ago. So he unfortunately died prematurely. In the US, von Lockham from New York and other people talked about removing vertebral bodies as early as 1933 and was published at that time. Japan introduced anterior interbody fusion in the lumbar spine, and that was their contribution. From my own viewpoint, adult scoliosis, only the occasional case would be done prior to the late 60s. Nielsen from Sweden published a few cases, and I published 90 cases in 1972, which began the era of adult deformity surgery. The halo was introduced from Los Angeles by Vernon Nickel and Jacqueline Perry, and you can see here the halo attached to a cast, and this really was a major advance in the treatment and immobilization of deformities in all aspects of the spine. Ron DeWald from Chicago introduced the halo pelvic device. It was popularized by O'Brien from Hong Kong. This is the device which I used in about 100 patients. Here it shows it on. This was a strong force for correcting deformity, but it was very awkward, difficult for the patients, and there were complications, including many occipital cervical problems. Other devices shown here are shown as well as halo pelvic devices. But very interesting, the halo traction has returned in a big way for the treatment of severe deformity. The original teaching was if you put a patient in traction for 10 days, that's all you needed. You didn't get much after that. Well, nowadays, for severe deformities, kids are kept in traction 3 and 4 months and allowed to be mobile in wheelchairs or walkers, and it does have a significant impact on very severe deformities. Unfortunately, we don't see much of that here in the US anymore, but if you go to Africa or some of the other countries in South America, severe deformities are still seen. Major influences also in the 60s came from Australia and Hong Kong. Dwyer was a very wonderful gentleman, picture here, introduced anterior screw fixation together with a titanium wire, flexible, for the correction of thoracolumbar deformities. He unfortunately died prematurely from gastric cancer. This is a case which I did in the 80s, early 80s, in an older woman, progressive deformity, and you can see here, the problem with this, you got a fusion, but you lost lordosis. This lady, fortunately, however, did well until she died some 10 years or so ago. Out of Germany, this man introduced anterior semi-rigid rods, and the first to introduce derotation of the spine. This is him on the left side, together talking with John Hall from Toronto and Boston, and the derotator applied there, derotated the spine. This was a very effective technique. And unfortunately, because of some problems with the abdominal wall, this lost popularity, particularly with the introduction of pedicle screws, but I think there will be a revival of anterior surgery now that it can be done through smaller incisions. And again, here's a case which I did many years ago. And when I looked at my own result, all in adults, you can see under age 30, 72% correction, Cobb angle, over age 50, 60% only, and there were no pseudarthrosis in the first 57 cases. Needless to say, the 58th and 59th cases did have pseudarthroses. Now, sublaminar wiring was introduced in 2 parts of the world, very close together, in Portugal by Resina and in Mexico. And it was introduced for the same reasons that Harrington introduced his rods. In Houston, where Harrington practiced, the summers are awful. Humidity is 100%. The temperature is 100 degrees Fahrenheit. So putting a kid in a cast or an adult was barbaric. So both Harrington, Zielke, and Racine introduced more fixation to avoid using casts. And here's a picture of Eduardo Zielke. He initially married Risser's daughter. They subsequently divorced. He died too prematurely as well. Hope that's not a forebear for spinal surgeons. But you can see here the sublaminar wires passed around, in this case, a rod, a Harrington rod, and this greatly increased stability. Now, very interestingly, prior to the introduction of this rigid form fixation, PJK in adults was rarely ever, if ever, seen with Harrington rods. It was the introduction of more rigid fixation that seemed to introduce this. And I saw my first cases of PJK with this form of instrumentation. It was modified for fixation of the pelvis by the people in Galveston, Texas. And this just is an example of a degenerative scoliosis, a paper, some 45 patients, which we wrote about in the 80s. And you can see here a Harrington rod with sublaminar wires and the lateral. Now, the 70s and 80s were really the introduction of pedicle screws. First introduced in Vancouver as a facet fixation technique, 100 miles away from here. Roy Camille, unbeknownst to the rest of the world, from France, introduced pedicle screws in the 60s, but nobody heard about it outside of France. I did my first pedicle fixation in 1973 in a spine trauma without knowing what I was doing. Fortunately, it worked out. Art Steffi here in the US really popularized it worldwide, and Jean Dubasset and Cottrell from France, and I did my first CD in 1986. And this all ushered in the modern era. There's a picture of Roy Camille, a fantastic man, a real gentleman, fun guy, loved to drink with him. He also was a major connoisseur of wine. You know, every spring to the United States, 747s come with cases and cases of Beaujolais Nouveau. And I said, it's not possible. France cannot produce so much Beaujolais Nouveau. It's not possible. And he said, Jean, tu es correct. You're right. And I said, where does it come from? He's 50% comes from Algeria diluted with water. So be careful when you buy Beaujolais Nouveau, okay? Now, CD, Cottrell Dubasset. Here is, you know, you recognize Dr. Dubasset. I first got to know him in 1969. We had both just finished training. We were at an SRS meeting in Toronto, and we've been friends ever since. He, in fact, brought a CD case to me in 1986 on the airplane by hand, gave it to me, and I did my first case. I think I paid less than $10,000. I'm not sure, maybe even $4,000. Anyway, I also gave Jean and his wife and the other French friends their first barbecued hamburger, which he remembers to this day. So there's one of my early cases of CD with hooks. Subsequently, of course, used screws, the knurled rod. A lot of people didn't like using this. They thought it was too fiddly. I thought it was great. It was easy to use. A lot of things have happened since. The big topics today are PJK and loss of lumbar lordosis. Now, loss of lumbar lordosis isn't all due to deformity surgery. The most common cause are low back fusions, 2 levels. 60% of lordosis is at L4 to the sacrum. And when patients are fused with pedicle screws, especially with their hips and knees in a flexed position, they'll get a flat back. And the most common cause for an osteotomy is flat back surgery, secondary to low back surgery. This is, and we've seen a great evolution in the amount of bone resected over the years. And this has been classified and shown in many ways. I do believe that the future of deformity surgery is really is minimally invasive, in particular for degenerative scoliosis, and this is going to be fantastic in the future. Instead of doing big incisions like this, we'll do smaller incisions like that. And it'll really change. Today's techniques are far more effective and use many different procedures to correct deformity. It's an exciting time, and I'm so pleased to see so much better surgical procedures being used throughout the world today. But as I think the future really does lie with robotics, not so much for guidance, but for the robot who will actually do the surgery. That's about 15 to 20 years away. There's a big regulatory process, but that won't take away the surgeon. There still will need to be the surgeon, believe you me. And all this other thing is going to happen, but outcomes, which we talked about. So the future really is extremely bright, and after I quit surgery 11 years ago, I thought I wouldn't miss it, but the last 2 or 3 years, with all the significant advances, I really do miss doing surgery. So I may go back and do another residency. Thank you very much.
Hey, thanks for visiting the Seattle Science Foundation YouTube channel. To find videos just like this one, click here. To subscribe to our channel, click right here. Or check out our website here, or see what we do by clicking right here. Thanks again for watching.